in terms of toxicity profile, there are certain breakdowns by disease type, but the ones that we've seen most notably in terms of toxicity are the infusion-related reactions. So that is, seen in other IV similar monoclonal or bispecific antibodies, but is, usually fairly surmountable by pre-medicating as recommended, usually with Tylenol and Benadryl and as corticosteroids as well. There are, some patients who have GI toxicity, diarrhea, nausea, vomiting. It's always a little hard in these single arm studies because there's no placebo control. How much of the toxicity is related to the drug versus the disease state? In this case, patients with, refractory pancreatic cancer. So because there's no control arm, placebo arm, it's impossible to know fully. Clearly, the infusion reactions are related to the drug, but some of the other toxicity, it's always a little hard to determine 100%.
Yeah, absolutely. I think mechanistically, we might expect, targeting molecules in the ERB pathway. Some diarrhea, it was an incidence of 18% overall related diarrhea. Almost all of those were grade 1. In fact, there were very few grade 3 or higher toxicities overall, less than 10% in some, and really none greater than 1%. You can see some fatigue, you can see nausea, anemia. Those were, again, mostly grade 1. And to your point, some of those may be disease-related, a little difficult to tell. I think one good measure of tolerability, which really is a subjective term, but if you look at how frequently do we stop drug, do we discontinue therapy due to adverse event? In 204 patients who received this drug, one case. It's only one case where we had to stop treatment due to adverse event, I think really speaks to the tolerability of this drug. It is an infusion every 2 weeks. Infusion reactions are something to monitor, but overall, I think a pretty well-tolerated drug.
To your point, about 2/3 of patients had some sort of adverse event, but thankfully only 7% had a severe grade 3, 4 adverse event, and goes to your point of tolerability and also that very few patients had to discontinue the drug due to toxicity.
So the approval of zenocutuzumab was for non-small cell lung cancer and pancreatic cancer with an NRG1 gene fusion, though we did see responses really across tumor subtypes, and I think it's a reasonable option regardless of tumor type. In the lung cancer world, this really is our preferred second-line option, although we know from retrospective studies that the frontline options of chemotherapy with or without immunotherapy perform pretty poorly. And so these are patients that we have to monitor closely, switching them to zenocutuzumab very quickly the first time. That's where you really want to have this information before you start frontline treatment or very early in the course. And so in lung cancer, this has become de novo second-line treatment. I think that for other tumor types, it should be consideration after standard treatment. Ben, in the current pancreatic cancer landscape, where would zenocutuzumab fit for an NRG1 positive pancreatic cancer?
That's a very good question. We get this question all the time when discussing patients with metastatic pancreas cancer who are on like frontline chemotherapy, usually FOLFIRINOX, and you find one of these. What do you do? Do you stop the chemo? Do you switch to Zeno? It would make me kind of de-escalate that chemo much more quickly, in part because we know the longer you continue on sort of similar dosing of those drugs, especially oxaliplatin, that you're getting higher rates of potentially permanent neuropathy and less sort of clinical benefit. So if we find something that's actionable, it may not make me stop the chemo tomorrow, but it probably would make me stop the chemo, within a month or so, and try to de-escalate and then switch over to Zeno. As you stated, the drug is approved for non-small cell lung cancer and pancreatic ductal adenocarcinoma in the setting of an NRG1 fusion. It'll be interesting to see down the road if there's some expansion of that approval. In the New England Journal paper, there were other disease types included, including cholangiocarcinoma, which is also a very difficult to treat tumor. And what do we do with a patient who has an NRG1 positive cholangiocarcinoma, but without an FDA approval? Can we get that via some sort of compassionate use, et cetera? The other thing that excites me from a clinical trialist perspective is there are some interesting preclinical data of combining drugs like zenocutuzumab with some of these newer KRAS inhibitors, and that through some of the kind of parallel pathways, there might be a way of reducing resistance to some of these KRAS inhibitors that target these more common KRAS variants like KRAS G12D in pancreatic cancer, which is not approved yet. But of concern is, the drug seems to work, but breeds resistance pretty early Can we combine it with other KRAS inhibitors, chemotherapy? I think combining with other targeted agents like zenocutuzumab, even outside the NRG1 space, might prove fruitful based off some preclinical work. So that's an exciting potential drug development story that I hope will bear fruit in the future.
Now, Ben, we've been participating in this trial for quite a while now, and I think you'll agree, real challenging to conduct a study in this space. So quite a feat to complete this study to lead to approval. I think it really took a global collaboration because these are rare events. They are difficult to find. Patients are often quite ill. And I think that would make a placebo-controlled follow-up to this extremely challenging, right?
Right. And thankfully, the FDA allows these accelerated approvals based off typically response rate and duration of response, which was the story here. To conduct a randomized placebo-controlled trial of something with such a low incidence is impossible and will never happen. So getting patients access to a drug that has clear both clinical activity and also clear safety is really vital and is a very important usage of this pathway, which I think often gets somewhat ridiculed because it's not a randomized placebo-controlled trial. But if you look at the overall picture, that type of effort would really prove impossible, and these drugs would never be able to be developed.